Oh, there we go. No, it'll be on to the Teams.
Yeah, it'll just record what's on the screen. Do you want to do lunchtime?
Are we happy it's ready? Yeah. So this was asked by people, I think, in response to the fact that everybody sees oncology patients, especially at the weekends and often during the week, especially recently. And so I was asked to give an update to everybody, a sort of whistle-stop tour of neuro-oncology, types of brain tumours that you might see in patients on the ward, and a few extra bits. So I've got a few slides to go through, a bit of question and answer, and then happy for you to ask anything about anything neuro-oncology. So the first few slides are, I've got a question and then shout out some answers and then the answers on the next slide. So has anybody done this before? Ages ago. You have. Remember any answers. Okay, that's good. You might not be able to participate in some if you can. So how many different types of brain tumour are there? Anybody want to throw a figure out there?
I want to say like hundreds, yeah. But I don't know if that's ridiculous.
Hundreds? No, not ridiculous. Any other guesses?
Four.
Not
Either that or malignant, non-malignant. Yeah.
No, it's not that mean. Over 130. So you were close with hundreds. Although I will say that probably the vast majority of the types of tumour that you see are probably about 10 to 15 out of that 130. So there are a huge number that are incredibly rare that even we rarely see and would need to research or Google at the time. But in total, over 130, they can originate in any part of the brain or spinal cord, and we'll go through in what cells specifically in a minute. And then normally named after the type of cell that they arise from. Who gets them? Anyone. Sadly, yes, anyone. There are still no known risk factors whatsoever, which is why our patient caseload ranges from 18 as soon as people hit the adult service until, with no maximum limit, and anywhere in between. How are they graded? Lots of you might know this a bit already.
Low grade and high grade?
Yeah, low grade and high grade. And by numbers, how many numbers have you got within that?
1 to 4. 4 or 5.
1 to 4, somebody said. Yeah. So Fran, was that you? So it's the World Health Organization classification, although I do need to update this slightly because there's some recent updates that have changed this, and there's a bit more merging between 2 and 3 based on new testing that's available. That means that we can now detect some 2s that actually have features of a 3. So it's not quite as black and white as these grades suggest. However, it's a good way to think about it because most people will follow a general trend of being 1, 2, 3 or 4 and progress in the way that it says on the screen. So they're graded based on how the cells look under the microscope and how they behave, and then the specific histological testing. So they're generally divided low grade and high grade. Low grade being looking a lot more normal under the microscope and hence acting a lot more normal, which is to grow more slowly, not replicate as fast, not grow as fast, not spread into as much local brain tissue, not press on as many local structures. So 1 is at the very far end of the spectrum, looks really normal, slow growing, less likely to infiltrate local areas. 2 still look quite normal under the microscope, but can grow into nearby tissue. More likely than grade 1 to come back after surgery, and grade 2 can develop into a grade 3 and then into a grade 4. So grade 1 unless it's really atypical, grade 1 generally never transform and just stay a grade 1 forever. So they might regrow over a number of years, and they might need to be resected at later down the line or re-resected, but they don't change, they don't morph into something more malignant. They just, unless it's a atypical tumour, they just stay at a grade 1 and don't cause as many problems.
Is grade 1 still classified as being malignant?
No,
That's a non-malignant.
non-malignant. So they're called, we can call them tumours because tumour's just an abnormal growth, but they're not cancerous, which actually is a real problem for a lot of people, because load of the brain tumour charities are actually cancer charities. So they only, so you have to have a cancer diagnosis to get any support from them.
What's the daffodil one? They I remember trying to get it for someone.
Yes, yeah. Well,
Macmillan, because they're
and
they were a meningioma, which is a
great, 1 or 2, which is not classed as cancerous. So it's, in a way, some people get a lot more support, and if they've got that label of it being a cancerous tumour. But there are brain tumour charities who do, and who span the whole grade system, but just the cancer charities, it's sometimes hard to access, like financial grants if people aren't working and things. And then 3 or 4, so 2 can become 3, 3 can become 4, etc. But grade 1, unless atypical, stays at a grade 1, but can still cause problems depending on where it is, if it's in a really delicate location. So 3 and 4 look much more abnormal and behave more abnormally. So they multiply a lot faster. They spread, they can even spread within the brain, so they can have different deposits in different areas, or they can just grow into nearby tissue and then compress everything. And 3 and 4, so radiotherapy, according to the NICE guidelines, radiotherapy and chemotherapy or one or the other, or a combination of both, depending on the specific histology of the cells, are advised for grades 3 and 4. And now, because we've got the new system, sometimes grade 2 if it's got these more malignant features. But grade 1 would never be recommended for radiotherapy, chemotherapy.
Can I just ask, if they, to like grade them, I guess you're talking about the microscope, do they sometimes like preemptively grade them from like clinical picture, and if they're how they're progressing?
Yes.
And then they definitely grade them when they've been under the microscope.
Exactly that. Yeah.
Yeah.
So they're very vague with patients until the point where they've got the final histology, but they will say, you'll see it written in the clinic letters, that it looks suspicious of a more malignant tumour. So they will broach that with the patient, maybe at the point of diagnosis, like the first clinic appointment, pre-op, pre-treatment, but they'll never commit to that. Even in surgery, they send off the frozen section. So you'll see in the op note, it says frozen, so they'll take a little bit, taxi it over to St James's, and then it'll come back whilst they're still operating, so it guides how much they resect. And even if that comes back as grade 4, they still won't commit to telling the patient that until they've got the full histology, because they might have just got the one tiny bit that was a certain grade, and then the rest of it might be a different grade, and they don't want to give the wrong news and then it'd be worse later.
And how long does it take for histology?
Well, weeks. So you've got diagnosis. If it's high grade, then you're into surgery within a week normally, so maybe 5 or 6 days. But the low grades can be weeks between diagnosis and surgery, and then you've got had your surgery, recover from your surgery, and then it can be another 2, 3, 4 weeks before you get that final diagnosis. So it's a massive amount of time to be thinking, well, have I got 10, 20 years to live, or have I got 1 year to live, to be waiting for that news. So it's a long time. So brain tumours never spread outside the central nervous system. I say never, as in it would be very, very rare. So they just cannot spread. And it's still, I've Googled this so many times, I still have no idea the explanation, because it's so in-depth and they're all theories. But it's not to do with the blood-brain barrier, because you can get metastases into the brain and spinal cord from lots of other places, but it never metastasizes out. Just something to know.
A good thing.
Yeah. It's one silver lining. It's not going to be anywhere else, but it can spread to different areas of the brain or spinal cord. how many individual cells are there in the human brain? I've had some really good answers to this before.
Lots.
Infinite.
Lots and lots. Well, what?
Maybe like a trillion.
You're roughly in the right realm. I don't know. How many millions?
A million. Is it? It's a million, isn't it? A trillion.
I know, but I'm just also conscious this is being recorded. Trillions. Someone's listened.
Maybe scale it down one factor.
A billion. Millions.
But
Billions.
Billions. 170.68 billion cells in our brains. And specifically, that's roughly half. That's roughly half neurons and half glial cells. And we'll go through that now. So you know how they're always described as gliomas, the brain tumours. So a glioma is a very, very broad term for any tumour that originates from a glial cell. So all of this, basically all the cells in your brain are glial cells. So it's just a way of saying they've got a growth in the head. So it's not very specific about, it doesn't tell you the grade, it doesn't tell you the location, it's just they've got a growth that we don't know about what it is in the head. So these are the different types. So this is obviously relevant to tumours, but it's relevant to any neurological damage, really, because it's these cells that are going to be disrupted in any traumatic brain injury or hydrocephalus or anything. So I have got some notes on this bit because there's a lot of detail about what these individual cells do. But essentially, the ependymal cells are you might recognise them, they're a bit like the ones in the lungs, aren't they, with the cilia. So they're the ones that line all of your ventricles and your spinal cord. So they're the ones with the sort of cilia, and it basically, well, the notes I've got say ciliated epithelial cells that line the inner walls of the ventricles and spinal canal, and they secrete CSF. So it's their job. And because the type of tumour originates from the type of cell, if you get a tumour originating from an ependymal cell, what do you think the tumour might be called?
Ependymyome.
Very close. Very close. Because they're all mostly ependymoma.
Okay.
So that's a clue for the next one. And then, so oligodendrocytes, another type of cell, that is the equivalent of your myelin sheath, your Schwann cells in your peripheral nervous system. So the myelinating, insulating cell that kind of wraps around the axon of the nerve to transmit signals is in your central nervous system, they're called oligodendrocytes. They're just slightly different to the Schwann cells that you can see there. So they provide support and insulation to the axons of neurons in the CNS. They create the myelin sheath around the axons, and they're the equivalent to Schwann cells in the peripheral nervous system. So their job is mainly insulatory. If you had a tumour originating from your oligodendrocyte, what would it be called?
Oligodendrocytoma.
Yes, excellent. And then your astrocytes. So I can't do this training without doing Shannon's astrocyte. And what does it do for ependymoma? Astrocytes are like star-shaped, hence astro, so Latin. They help provide. They're the nutrient givers, so they help provide nutrients to neurons, help with biochemical balance, regulate cerebral blood flow, and they're involved in the process of repair of brain tissue. So I imagine they're quite important for neuroplasticity. And microglia are the last ones in the central nervous system, and they are like your defense system. So they try and kill all of the cells that turn funny and start multiplying and could become cancerous, but your body fights off millions of cancerous cells all the time, doesn't it? And it's only when it's unable to do that that it turns into a cancer. So the microglia are your brain's active defense mechanism. And it's resident macrophage cells. They scavenge the CNS for plaques, damaged neurons, and infectious agents. And they're extremely sensitive to small pathological changes within the CNS. So they fight infection as well. And then peripheral nervous system. So you've got your satellite cells and Schwann cells. So the Schwann cells, like I said, they support the neurons in the peripheral nervous system, similar to the oligodendrocytes, and they wrap around the axons of sensory and motor neurons to form the myelin sheath. And the satellite cells, similar to astrocytes, supply nutrients to the surrounding neurons and express a number of receptors that allow for interactions with neurotransmitters. So you just don't need as many different types of cells in your peripheral nervous system, I don't think, 'cause it's not as complex, more of a relay system. And this is sort of how they all fit together. So you can see the sort of neuron itself, and then the way that the oligodendrocytomas wrap around the axon, and the astrocytes sort of communicate between different axons, and how the ependymal cells line the ventricles and spinal cord. So a lot of the ependymoma patients that we get will have the primary problems from their tumour, and then often a load of problems with CSF flow and CSF management, hydrocephalus, and will need potentially the whole sort of EVD and shunt surgeries in addition to the tumour resection, because anything growing from those ependymal cells is going to grow directly into or compressing your ventricular CSF system. So it makes sense that they would have problem like Emma Williams. Does anybody know Emma? So she's got it's like a craniopharyngioma, but it's essentially a type. It presents similarly to the ependymomas. So, and she's had massive problems with CSF management and postural change. So you can kind of, you know what to expect from. So
do any of the others give you specific problems like that? Because obviously the main problems we think of are from the space it's taking up, or whatever pressure it's put on, or the damage from the surgery. Is there any other ones that give?
Not in that same way, no.
I forgot the word already.
There's hemangioblastomas, which originate from cells in the lining of the blood vessels.
Okay.
So I suppose some patients have then like embolic events or stroke type events or hemorrhages in addition to the problems caused from the growth of the tumour. But these ones, like the astrocytomas and oligodendrocytomas, they generally are just location specific. Does that make sense? Types. So I'm not going to go through all 130 types, don't worry. But these are some of the most common ones that we see a lot on the wards. So most common type of high-grade brain tumour in adults, and actually over 50% of all primary brain tumours, which is pretty shocking, is the glioblastoma. And let me just get to my... So on the grading system, it's the grade... Every glioblastoma is a grade 4. So it's the fastest growing, most aggressive, most likely to spread, not outside of the brain, but into nearby tissue. Its full name is a glioblastoma multiforme, which is shortened to GBM, which you'll often see abbreviated in the notes, and that's because they've got highly variable cellular makeups, and then hence the name multiform. And they're not made of just one type of glial cell. They're just loads of different glial cells that start misbehaving. So it just means, I think that's part of the reason why it just grows so quickly, because it's not even just one cell that's started transforming. It's just a load of different ones all in the same place. And despite all the advances in medical technology over the last 20 years, the average prognosis from diagnosis to death with a glioblastoma has not changed in the last 20 years, despite all of the advances in testing and radiological.
And what is it? What's the
12 to 18 months from diagnosis, almost regardless of age. So yeah, not long. And this chart is from the Brain Tumor Charity website. Has got some amazing resources, and they've got a charts like this on all of the different types, so it shows you sort of what the primary treatments were. So this is the treatment that the patient received first. It's not the only treatment they received, but you can see that blue. No wonder we get so many patients through with them, because the biggest chunk is surgery that people have first to slow it down. Although a really shocking fact that I found was surgery, when we do see this, and I've had this quite a few times, and I've only recently kind of become aware that it's a proven thing, that surgical resection of GBM can in some cases stimulate the cancerous cells that are left behind to grow up to 75% faster than they did before the surgery. So
But not in all cases, that just sometimes happens.
Just sometimes. And
And do they have a rate of what that risk factor is?
I don't know. That's from the Glioblastoma Foundation, so I need to do some more reading. But I have genuinely seen that, and I thought somebody who's like progressing slowly but is doing quite well and it's regrown, and then they have surgery, and then literally within a few weeks it's like totally downhill, and you think, but there's virtually no tumor left at the moment, so it can't be that. But it is, because it stimulates growth up to 75 times faster.
Patients told that information that they go for surgery.
I don't know. It'd be very interesting to find out. I've only been to clinic like once in years ago, so I don't know exactly what's said. It's not documented in the clinic notes. So astrocytoma. About a third of all brain tumours diagnosed are astrocytoma, and they can be, like I said, you can get one that's grade 2, or you can get one that's progressed and is more malignant and is a grade 3, so you can just see it's having more effect on midline things. More the white around that, the tumour is actually only this encapsulated bit really, and all of the white is edema. It's really common to get a lot of edema around brain tumours. Let me see if I've got anything else. Yes, they can be both low grade and high grade. Slow growing if they're lower grade, and have because they're like stars. Imagine them with like lots of different. I know this is the cell, but also reflects the type of tumour, because they have all these tendrils that grow into tissue nearby. So they're not very uniform, so it's hard to get a really good resection because you can't follow all the tendrils. It just looks like normal brain tissue, so you can get the kind of core of it, but you've got all these bits that grow off, so they often regrow quite quickly, even if you get a good resection. Whereas something like a metastasis, if you get a brain metastasis, it's often almost fully encapsulated. Sometimes when you go into theatre, they almost like pop out, because they're just in this, because it's a different, if you've got a metastasis, it's either breast tissue or lung tissue or kidney tissue that's growing in the brain, so it tends to keep itself more in a little pocket rather than spread out in tendrils, because it's not actually a brain cell primarily. Vestibular schwannoma. Now everybody will see on ICU, especially over the weekends, because they pretty much always go down to ICU post-op, at least for a few days. Vestibular schwannoma is the correct term. Acoustic neuroma is a bit of one of those umbrella medical terms that's not very specific, so we really should call them vestibular schwannomas, because they originate from the Schwann cell, which means that they're actually a peripheral nervous system tumour, but still come under us because of how close they are to such important structures. So they often have a really significant neurological deficit. I think it's the only peripheral nervous system tumour that we actually see. I think everything else is within I think they'd go to somewhere else if they were peripheral, like arms or legs or whatever. So yeah, compress a lot on cerebellum, brainstem, cranial nerves, and especially facial nerve, which is why people have such a pronounced facial weakness post-op often. And people can present with, because they're so slow growing, low grade. These are always low grade tumours. They're slow growing, so you can get sort of really gradual hearing loss over a number of years, or tinnitus, or some mild balance impairment that you don't necessarily even notice and just compensate for because you've got another ear that works normally. So yeah, hopefully, but then the really severe ones would have brainstem compression and then go down the trachea route, I guess, post-op. If a schwannoma is genuinely a vestibular schwannoma, it means that it's growing from the vestibular cranial nerve, which is the 8th cranial nerve, going from the pons, or I think the pons, maybe the medulla, in your brainstem around to your vestibular system at the back there. But if occasionally we get people who are actually got a facial schwannoma because the tumour originates from the 7th cranial nerve, which is the facial nerve, but for some reason they mostly grow off the vestibular one. Again, I don't know why.
If it's actually growing on the nerve itself, once it's been resected, do you go down like a treatment route to get it better, or is it more a compensatory route that it will never get better? You just need to learn different strategies.
That's a very good question, Fergus. So the primary deficit, so something like hearing probably will never come back, or rarely comes back if it's been present pre-op. But most of it all depends how somebody was before the surgery. If they had a really significant balance deficit before, there's a chance that there's been compression for long enough that there is a deficit that's can't return to normal function. But most of the time, people just have hearing loss or tinnitus or something of facial beforehand, in which case there's potential for that system to plasticize and get back to normal, because it's the direct effects of the surgery, the resection itself, that have caused all of the post-op picture. So normally when people do go through active rehab, sometimes a bit of compensation in the early stages to allow function. It's actually a debate that we have a lot about giving, because these patients they don't have a dense one-sided weakness, they have kind of vestibular orientation problems, coordination. So they're often able to get up and about quite quickly, limited by nausea and dizziness. And we tend to give them something like a frame a lot earlier on now to allow them to be up and mobile with the nurses a lot more early on, so that they can begin to adjust and plasticize and get the exposure to being on their feet, and they challenge their vestibular system early so that they can hopefully rehab and get to a better outcome more quickly. Whereas we used to kind of limit them, not give them a frame because they would fix through it and they wouldn't be posturally as active, but then they'd be like in the bed or the chair nearly all day, not doing anything. So then they wouldn't be exposed to their vestibular system being challenged, and we felt like it limited them in the long term.
These are different to the CP angle.
Yes.
That's not just a different name.
No, but very can be identical,
like similar
presentation.
symptoms. Yeah, that's what I was thinking. Yeah,
exactly, because they're in almost exactly the same place.
Yeah,
but they're just not originating from specifically the 8th cranial nerve. Meningioma, cerebellopontine. But if this is growing from something that exits the pons, and then you've got a cerebellopontine meningioma, they're almost identical.
So the surgery symptoms would be similar, but maybe the initial tumour symptoms might be a bit different because you're not right on that nerve.
Yes, exactly. Yeah, exactly. Yeah. And meningioma, although that's not a CP angle. So as the name suggests, originate from within the meninges surrounding either the brain or the spinal cord. So we see spinal meningiomas and cranial meningiomas. Typically grade 1, but can progress to grade 2. And now that they've got this extra testing, can progress to atypical meningiomas, which class as a grade 3. So can actually become more malignant now that they can test for it. I think they're pretty self-explanatory. So they're not actually invading the brain tissue itself, but they compress everything that is underneath them. Oh yeah, this is the blood vessel one, but it's only 2%. So I would say we'd only get, I don't know, a couple of these a year really. So I always have to refresh myself. Originate from blood vessels. Yeah, they're generally low grade. And there was definitely a lady in recently who had either this or something similar, or who was under, was it spines or was it you? Who had a hemorrhage from a blood clotting disorder. And one of the common ones is von Hippel-Lindau.
Von Willebrand.
Von Willebrand, that's
That was a
it.
lady, she was Joy's patient.
Yeah. Oh, she
Her
was
teacher or something,
Yeah, she
wasn't
was.
she?
Can't remember her name.
Probably shouldn't say names for
Yeah.
YouTube.
Wow.
You can just
I'll blank that one. Actually.
I did before as well. That one, von Hippel, where are they all von? Von Hippel and genetic disorder involving a mutation of a protein which makes people more susceptible to visceral
There
tumours.
must be some research centre into like vessel diseases
Yeah, in
somewhere like Denmark.
Yeah.
Where they're all called like von something.
yeah, von
German. It's like
Willebrand.
German or
Yeah,
Danish or
I
something,
think,
isn't it?
isn't
The von traps.
Yeah. And CNS. And CNS lymphoma, just under 5%. So again, not many, and can occur. So they occur in the cells divide in the lymphatic system, but then can deposit in, because they travel through everywhere else in the body, they can kind of start multiplying in the brain or spinal cord. And they're generally quite aggressive, but people often go from here as an inpatient across to St. James's because they can have really aggressive, I think it's chemotherapy, and then it can affect the cells really quickly and they can functionally get a lot better from the treatment. Whereas with brain tumours, it's like you have to be functionally good enough to access the treatment. Whereas it's kind of the opposite with lymphoma. They know that the treatment is so effective that they can kind of whack them with the chemo and then they're able to function a lot better. So they just go straight over as an inpatient normally. Oh, treatment. We've already said the answer. So surgical biopsy, debulk and resection, that's our side. And then normally, so some people never go through surgery. Some people just, if it's depending on location, if it's too difficult to access surgically, or if there are multiple sites, like multiple Mets that are all quite small but are growing, then they might just go straight to Bexdoing for chemotherapy and or radiotherapy. But the higher grades of ours will go surgery and then oncology.
Do LTHC do gamma knife, or do they have to go to Sheffield?
They do gamma knife at Jimmy's, yeah. And I still need to know more about that. And I know it's a really targeted form of radiotherapy. It's over just one day rather than sometimes people need like Monday to Friday, 3 to 4 weeks of radiotherapy, sometimes 6. So gamma knife is really good for defined targets because it's about 200 different rays that I know it's the same as radiotherapy in principle, but yeah, it's a lot less demand on the patient, but I think only certain people qualify for it. And if you've got multiple sites, or a lot of our patients still need the whole brain radiotherapy, which obviously then in the healthy tissue can cause early cognitive changes. So they try and delay it as long as possible because you can get radiotherapy associated like dementia and things, even, a few years after you've had radiotherapy, even if you're in your 30s, 40s. So the specific histology they get back will determine which specific type of chemotherapy they're offered. There's a specific scale that we use, and people have to meet a certain functional level to be offered radiotherapy and chemotherapy because of the toll it takes on your fatigue and your if you imagine you've got to travel from home every day, Monday to Friday, for 6 weeks for a course of radiotherapy where you've got to go in, sit in the waiting room, stand up, walk into the treatment room, lie down on the radiotherapy bed for a period of time, get back up, get back into the waiting room, maybe see a couple of people in clinic appointments, and then get back in your transport, go home, and do that every day, Monday to Friday for 6 weeks. And you think about what the fatigue and energy levels of some of our patients, it's basically with the way that the tumours progress, if you weren't at a level where you could tolerate that to begin with, then either people just have to stop, or it kind of wipes them out so much that then the balance of quality of life and longevity of life is not quite right. So that's why it seems a bit harsh, because you think, oh, what about all these people who could be given extra treatment? But it's based on a lot of studies about ability to tolerate it and what benefit actually provides to quality of life. Does anyone know the criteria that's used?
No.
It's called the Karnofsky performance status, which is in the NICE guidelines said that it quite clearly says people need to be a 7 or more, which means, so it's a scale that goes from dead to normal activity. And I sometimes think, really? But then I suppose zero's got to be something, hasn't it? So 70 or above is actually quite independent. So caring for yourself, unable to carry on normal activity or do active work. So it's not like going out to work every day, but 60. If you think somebody who scores a 60 might not qualify, but that's only occasional assistance and able to care for most of your own personal needs. So it's still not very dependent to be offered.
Do we get many of those? Like, what do these patients look like? Do they all look like that? I don't know.
Well, that's why sometimes we'll see people who have who are trying to hit this score within a couple of weeks to be able to get onto their chemotherapy, radiotherapy. We'll prioritise them every day, regardless of what the rest of the caseload looks like, because unless they meet that within 2 weeks, they're not going to get a potentially life-prolonging treatment. So we do have a lot of people who hit 70.
Yeah, they do.
Yeah.
I feel like whenever I do like help with oncology patients, they're like so vast, and I know that is the same with the other neurosurgical patients. Maybe it's just because you're like seems more concentrated, but sometimes I just don't know what you're going into, and I guess that's just experience because you guys do. But I feel like sometimes they're just walking wounded, and then sometimes it's absolutely catastrophic, and I never know what they're going to look like.
And all the low grade patients, the 1s and 2s, this isn't even relevant for, because they're not going to need. So a lot of the patients who have maybe like the more rehab patients might have more deficit because they've pushed the resection a bit further because they know they've got time to rehab and get better, and this isn't going to apply. So it's tricky. Oh, what symptoms? I'm not going to make you list symptoms because I think we're running out of time, but basically anything. Yes. But anything dependent on location, anything. So, I mean, there's some basic ones, but literally anything depending on what it's comprising, plus all the CSF management stuff as well. Where can people have end of life care? Yeah, hospice, home,
Hospital.
yes, hospital. I mean, I've put anywhere they choose. Obviously, if you wanted to go on a boat on Lake Windermere, it might be difficult, but the main place, like hospital, of course, home, nursing home, hospice. So it should be possible where in any residence or location that you choose. If that's the pathway, then the funding is obviously a lot more open to people. And then so obviously brain don't metastasize out anywhere, but lots of other cancers commonly metastasize into the brain. So a big portion of our caseload will be people who've had brain mets removed, but have another primary cancer that needs to be managed. So they've got sort of more going on pathologically that needs to be considered in terms of discharge planning and referrals to different services. So there are 5 sites that commonly metastasize to the brain and some that just don't for some reason. So the 5 that commonly do are lung, breast, colon, kidney, and skin. So they're the main teams. So we're having an in-service in the near future from the lung and the breast clinical nurse specialists to tell us a bit more about their pathway, so we can be more informed for when people come in with mets from those areas and where to signpost them to. And then, well, any questions, but also I didn't know whether it would be useful to just say the main community teams that we refer to from if somebody's going home over the weekend or something. So there's the Bexley wing is the main one, and you all know Alison Goldberg, don't you? I know. Well, there's an outpatient neuro oncology team at Bexley wing, just who only see neuro oncology patients, so brain or spinal cord tumour patients. So they're the main team that we refer to, but somebody has to be good enough to access outpatients to go there. So often the high grade patients who are going to Bexley wing anyway for their chemotherapy and radiotherapy will nearly always refer people who have any deficit in, because they're going to be in the building and they can be seen either side of their chemotherapy or radiotherapy time. They schedule it alongside. If they're not good enough, but we often do a dual referral, don't we? So there's the Neuro EST service, but that's just OT and speech now.
I'm not sure about speech. Definitely OT.
Definitely OT.
Yeah. And they will see anybody that's had surgery.
Right.
Which obviously is all which is community tumours. So
yeah.
But they're much more of the kind of cognitive type patients.
Yeah. So they're normally the mobile but cognitive, but sometimes good for like immediate upper limb stuff and functional.
Yeah.
So they'd be really quick to respond, wouldn't they?
Yeah, they're normally within a few days.
And then we just go off locality. I mean, you got to work with what's available, haven't you? But we will often refer to neighbourhood team for if there's any ADL needs. So I know it's very generic, but it's the only thing that responds quickly sometimes. And then we just go to locality therapy, like community therapy services, same as everybody else. So my therapy.
The bit I find difficult sometimes is deciding if they need that or not, if they've had like morbid issues and knowing like how they're going to improve from their different kind of tumours. And I never know. Sometimes I just end up referring people because I'm like, oh, I'll just cover then, but it's hard to know sometimes what recovery we're expecting.
Yes.
Is my difficulty.
Yes. Well, having spoken to people after they've been discharged. So sometimes we'll do phone call follow-ups or see people again because they just come back in for a repeat resection. And then you'll ask them how they got on the last time. Basically, if anybody's got a sensory motor deficit, I refer them on, because if it's a new deficit, or even if they had one before and they weren't sort of fully at their normal level, I just refer them to a service, because the feedback that we get from people who come back in or who we speak to after they've left is that things are always more difficult than they think, or they don't progress as they think. Even if everyone says, "Oh, I'll be fine when I get home," I always just, unless somebody's really reluctant, I always just say, can we just refer you? If you're totally fine when they get in touch, then you can just say no. But it's just having, I don't know, there's so many things that can get worse or progress, or just questions that people have when they get home that they didn't think of at the time. Having a contact, I think, is just, So, which I hate, because I hate doing referrals and they take forever. but I just refer anybody who's got a new deficit. And sometimes to multiple places, like we might have Neuro EST, neighbourhood team and Bexley wing, all just for one person, but it kind of covers all time scales then. And then they work closely together, don't they? So they often refer on to Bexley wing, even if we haven't.
To refer to Bexley, do we just do a neuro outpatient referral?
It's on PPM. Is that what you mean? On the
if
specialist?
We were to refer to like pathologies,
yes.
Is it the same one?
It's exactly the same system.
Yeah.
But it's just, instead of neurology, it's neuro oncology on the specialist referral. Yeah. And anybody can do that, definitely, over the weekend, in the week, anytime.
Sorry, what was that one for?
Oh, for Alison,
Oh, for Alison.
yeah, go on to specialist referral, and it's just physio, adult, outpatient, neuro oncology.
And that's only if they're having ongoing treatment at Bexley then, or?
No, it can be anybody. Yeah,
Even if you're out of area.
even if you're out of area, because it's regional unit. So even if somebody's nowhere near Leeds, they can still. But because it requires them driving or travelling into Bexley, I always try and make it really clear to and ask them if that's what they want. So say, you know, I can send this referral. It is a specialist service, and it's, you know, I could say I'd recommend it for you and your needs, but you need to be able to travel to Bexley. The number of times Alison will have that we'll still have that conversation with people, and they'll go, yeah, that's fine, and then they get home to like Dewsbury or something, and then Alison rings them a few weeks later and says, oh, to arrange your appointment, and they go, oh, I'm not travelling to Bexley. And you just think, oh, but I did ask. But it's different when you get home.
I guess if they do have mobility needs, like any other hospital appointment, they can have hospital transport, but does that depend on location as well? I don't know.
Yeah, they can have hospital transport, but I don't know.
You have to wait around like all day.
Yeah.
Yeah, it's not.
They pick them up, they might have an appointment at like 11, but they'll pick them up from home at 7:30. They have to sit and wait.
Yeah, I don't have many people. I think if that's what they need, often we'll just refer to community. Yeah.
I think it's hard because like some community areas are really responsive and then some are not, so it's quite unfair.
It is really,
Yeah.
and you think, so often you'll ring them up and make the referral, and then they say, oh yeah, we'll be there in 8 weeks.
Yeah.
You just think, really?
I had a lady the other day that you saw as well. Do you know who I mean? We were chatting outside.
Oh yes, yeah.
And she's an Airedale patient, and they would go out on the same day
Really?
that she was discharged. She's at Jimmy still.
Yeah, but that's really good thing.
Yeah,
And
yeah.
then Bradford Neuro community team are brilliant, especially if it's any, you know, like of the high grade. They prioritise high grade patients within
I
a
think they
week.
work closer, don't they, Bradford and Airedale? Because it's the same referral form.
Is
It
it?
just gets sent somewhere different. Yeah.
Yeah, but then if somebody is a grade 2 but has some of those strange features, so is more but still classes as a low grade, then they'll just be on the waiting list and they'll be out to see them in 8 weeks, and it's just so long. But sometimes Alison will speak, if there's somebody like that, sometimes we'll ring Alison and say, is there any chance you can get them in the next couple of weeks, just to have an appointment and then, you know, wait for the commute. But there's always a negotiation to be had. I think that's the only referrals that we do.
There's charity.
Charities, yeah. Charity.
When you work to a hospice, you know, someone's like deciding that the place of death is hospice.
Yeah.
That always feels a little bit tricky to
Yeah.
arrange from the hospital. How does, do you know how that?
Well, that then is taken over almost entirely, well, it should be on paper, by the palliative care team in the hospital. And they manage all the referrals to the hospice and the community palliative care team, and it should be a fairly seamless route, but it's just not. So yeah, often especially Sarah often picks up like a lot of the admin related to getting the person there, and so the referral itself, and then all the care plans that need filling out and things.
And is that always for inpatient hospice care? Because my friend that works in the hospice, she does like a lot of outpatient, like not outpatient, like community stuff from the hospice. So is that just to come under hospice care?
So that would be, because the hospices are amazing.
Yeah.
They've in fact, Wheatfields and St Gemma's, which are the two main ones that cover Leeds, have got the inpatient units, and they've got outpatients. They've got outpatient therapy. They've got classes. They've got like day centre things, and they've got community outreach.
Does like community visits as well. So if you're referring, I guess the palliative care team would specify what that's for.
Yeah, that would always obviously be somebody who's higher grade, and they would need a palliative for the referral to be done without us. They'd need a palliative care team referral as an inpatient, and then that would be facilitated through the palliative care team through to the hospice, but not always. So if we've got anybody who seems like they'd suit the hospice, outpatient or community service better than Alison, then we refer directly. So we've got an email address or a phone number. But I mean, I can send that round if it would be
Yeah.
useful for
I think
the,
it would be.
for the
Or just
hospices.
having a little sheet in the office even.
Yeah, on the
It's
wall.
like, yeah.
Yeah.
Not bits of paper, but
Yeah.
just something nearby.
Or if it's ever over a weekend, then we're more than happy for you to like make a note, and then next time you're in, just
Do that
like,
though.
yeah, or just talk it through on the whenever we're back in. Because sometimes it's hard to judge that. Yeah, and also it's if somebody's not come to terms with the diagnosis, suggesting hospice anything is sometimes not as a no-go for that person. So it might be that that's what they need, but they're not ready to take that step yet.
Or if they're well enough to go home, but they haven't got their histology back and stuff. and they
Yes,
actually don't have their
exactly.
diagnosis yet.
Exactly.
Yeah.
So you might need to go down the Bexley route, because then you don't need to go into, yeah. Any questions?
Thank you very much. Thanks, Ellie.
Thank
you.
Thank you.
How do we stop this? That?
Yeah.
Okay.
I had a thought partway through if that was actually recording your voice, because were you on?
No, she's on phone.
Fine. So I couldn't hear Ellie on your phone, I could only hear you.
Oh, don't say that.
I didn't want to say it halfway through, I thought this would be fine now.
So funny. It's still recording.
I mean, I was doing it.